everyone, and welcome to the GHAPPcast. My name is Kate Scarlata. I'm a registered dietitian with a GI expertise, and I work for myself in a practice called For a Digestive Peace of Mind outside of Boston, Massachusetts.
Hi, Kate. It's a pleasure to have the opportunity to do this podcast with you today. I'm Amy Ladewski. I'm a physician assistant at Northwestern Medical Center in Chicago, Illinois. I work within the digestive health system and focus on neurogastromotility disorders and see a lot of patients with irritable bowel syndrome with constipation, which is the focus of today's podcast.
Absolutely. So we decided to do this in a case study format. We're going to present 2 case studies and then just play off each other a little bit about sharing our own expertise in different areas of clinical care.
Great. So we developed these 2 case studies, and so I will start off with reviewing the first case study, and then we'll ask the expert dietitian a few questions on, how she would hone in on individualizing dietary interventions for our IBS patients. The first case study is a 23-year-old female graduate student with a recent diagnosis of IBS with constipation. She endorses abdominal bloating, distension, and discomfort. She reports having 2 harder, lumpier, so Bristol 1 to 2 bowel movements associated with a sensation of incomplete evacuation, and she's really having to strain. She's trying to manage her stress by eating healthy and exercising on a regular basis. And for the past month, she has incorporated wheat dextrin fiber supplement that she's hoping would be able to help her constipation or IBS, but she says that her symptoms are getting worse. So I see her in clinic, and, the first component that really stands out to me that we need to navigate is her choice in fiber supplementation. When it comes to fiber, a lot of providers and patients are really confused on where to start. When you go to a Walgreens or CVS, it is an entire aisle of different fiber supplements. The same if you were to be on, Amazon and Google or Google Fiber. We know there are 2 mechanisms for how fiber supplementation works for constipation. One, there's that mechanical, stimulating, irritating type of fiber, which is our insoluble fibers. And then there are our gel-dependent, viscous, water-holding capacity fibers. When it comes to insoluble fibers, ultimately, what I want to say, it's probably not the right fit for patients with IBS with constipation, as it can lead to potentially more irritation, more bloating, and more pain, and may not fully actually improve constipation benefits. In regards to the soluble fibers, we have the viscous and the non-viscous fibers. And that's where this wheat dextrin that our 23-year-old female has chosen to choose. Now, the issue with wheat dextrin is that although it's considered a soluble fiber, it's non-viscous, so it doesn't hold on to have the same capacity to hold on to water. And it doesn't have much of a laxative effect. And actually, its physiological doses could worsen constipation. We also know that wheat dextrin is highly fermentable by the gut bacteria. And as we know for our patients with IBS, that a lot of them describe gas and bloating as their primary concern, can just worsen those symptoms. Inulin is another soluble fiber with some of the same properties as wheat dextrin. And a lot of the times is an additive in a lot of supplements that it can be used as a prebiotic, but that's another one that can lead to a lot of bloating and gas. When you have a patient that's coming in and wanting to start with a fiber supplement for IBS with constipation, the best evidence-based fiber is going to be Psyllium, which is a robust water-soluble fiber. It's minimally fermentable, therefore less gas and bloating. And it's effective in maintaining those the gel-forming, bulking properties in the colon and can treat constipation. So that is definitely, a great recommendation for patients if they're looking for something natural, over the counter. Psyllium is a great option. Additionally, psyllium can come in a few varieties. A lot of patients may recognize the name Metamucil, which is easily accessible at most pharmacies. Other options are Consul, which is a little bit more natural. Kate Naturals is another brand that you could counsel your patients to potentially try. Like any fiber, you want to go low and go slow. Make sure they're getting enough hydration. They can start with 1 teaspoon to a tablespoon daily and ultimately increase up to 3 times a day. So let's go back to our case study before we refer her over to our expert dietitian. So she comes back into the office. We counseled her to try the Psyllium. She's been taking it for 3 to 4 weeks now. And she does say that it's promoting soft, informed bowel movements, but she says that her abdominal symptoms are still persistent. She's still describing the bloating and the gas, and she's looking for another natural approach. She said she's just not ready to start, an FDA-approved therapy that we reviewed, such as, the linaclotide, plecanatide, tenapanor. So she's really interested in navigating her diet. And she says, I just don't know where to start. Do I eat more fiber? Do I eat less fiber? Is there any belief in trying to go gluten-free? What about the low-FODMAP diet? So fortunately, as an APP, I make sure that I have a really great GI dietitian on my team and refer her over to, Kate to kind of take the lead in navigating the dietary piece.
Thanks for referring her to me. I, always initially start with getting a sense of what the patient is eating. It's a good, beginning stage to really understand how food may be a trigger or not for these patients. So a good question right off the bat, does eating trigger your symptoms? And we all know in IBS, the bulk of patients are going to say yes. But there is, that 15 to 20% of patients that's not the case. So we do want to make sure we ask that question off the top, because if eating doesn't trigger their symptoms, diet's probably not going to make a major difference in their symptom profile. So start there. And then I start with a good dietary recall. And, with all the TikTok lovely messaging out there, everyone's got the message that fiber and more fiber and more fiber is good because we want good, healthy gut microbes and yada, yada, yada. And that's, partially true. But some patients go quite overboard, right? And in this case, this young woman was really going pretty hard on the fiber. Whole wheat bread. She was adding a tablespoon of chia seeds with peanut butter on her bread. So 1 tablespoon of chia seeds, 5 grams of fiber. She was really loading up in the morning. And then she really did enjoy plant-based diet, which certainly I advocate for, but she was getting a lot of FODMAP fibers. Kidney beans, which are very high. They're probably the highest FODMAP containing bean. And that was the one that she was really loading up on her salads. And she was having marinated mushrooms and garlic and onion. And then, of course, topping it off with some whole wheat crackers, again, another FODMAP source at lunch. And she loves vegetarian chili for dinner. So then she was getting more and more legumes, a mix at dinner, and also including an all-fruit smoothie, which can be a great way to get fruit. But she was adding a protein supplement that had inulin in it. And, Amy mentioned the inulin and the fermentability of that and more gas. And inulin is added to a lot of protein powders, just slipped in there. So we want to keep an eye on that. And then what types of fruits was she adding? Well, she was having quite a large smoothie. This was, filling a 20-ounce tumbler. And so she was having over 2 cups of fruits. Some were low FODMAP fruits, but some were high. So I was taking an eye on that. And then she loves the Fiber One bars. And of course, the number one ingredient in those are chicory root extract. So just looking at that, sometimes with patients, I'll take a highlighter and I'll just highlight all the things that I see that are just so highly fermentable and go, these are the things that are contributing to your gas. And I don't want to take all of them out, but how can we tail back on some of these? I'm definitely in the camp of less restriction is always better. We want our patients to have a really beautiful relationship with food and a good quality of life related around eating. It's important. We know our GI patients are at greater risk for disordered eating, and it's something we don't want to exacerbate. And we really want them to nourish their bodies, but maybe not over-nourish with insoluble gassy fibers. So in this case, I decided to really kind of cherry pick out some of the things. Like, what could we do that would be a little less fibery? So with the whole wheat bread, that's has a lot of that whole wheat bran, and wheat bran we know is an IBS trigger. Just because of the insoluble fibers, but also it's rich in fructans, which is a soluble fiber. So it's a double whammy sometimes when you get into the whole wheat crackers, which this young girl was having, as well as the whole wheat bread. So I would have her switch up. Let's try some slow leaven sourdough bread, which is lower in fiber, or even an oat-based or multigrain bread, which tends to have less of the wheat and has a variety of different grains. Another change was the kidney beans. And I'm not going to put a negative spin on kidney beans. I'm just going to say, hey, let's try to choose one that maybe will have less of those fermentable fibers. In this case, chickpeas are a great choice. So let's put some chickpeas on that salad. So we're really cherry picking out what are some things. Why don't you add some carrots? Why don't we cut back on the garlic in the salad that you're adding? And so we just play around, look at a different protein. If she wants to use a powder in her smoothie, I'll give her another protein supplement. But I often recommend a lactose-free Greek yogurt. It's great fermented food, great protein source. So just kind of going through with some alternative recommendations where I'm reducing the FODMAPs, I'm adding variety, I'm not reducing calories. And quite frankly, I don't often use the term FODMAP because I don't want them Googling. I just want them to say, these are real gas, producers. Let's try to kind of cherry pick and move over here and see where you're at. We'll check back in a week or two and go from there. So that is how I kind of start in with this patient and go from there.
Thanks, Kate. I like your comment about, really not using the word FODMAP. And a lot of patients can become perseverative of it. There are so many different resources and conflicting recommendations online. As a provider, I think it's easy just to hand a patient a handout on the low FODMAP and walk away. Mm-hmm. That can be extremely overwhelming for the patient when maybe it's not an appropriate place to start. So yes, as a provider, I think we can comment on, that the low FODMAP diet is an elimination reintroduction diet, that it's complex. It requires the professional help of a registered dietitian before really delving into it, as I do think that sometimes it's a little overprescribed and we're not setting up our patients for success.
Exactly. And I would say, I'll pick and choose the right patient. There may be someone that is in severe, debilitating pain that can't get out of their home. It's clear to me that it really appears that their diet is a major trigger for them, and they may be the right candidate. Mm-hmm. On the other hand, we do have, clinical experience just cherry picking FODMAPs out, and it works. I mean, I've been doing this for a very long time. Mm-hmm. And we do have one study from Bill Che's group. Prashant Singh did a FODMAP gentle diet, and they did find similar efficacy of just cherry picking out certain FODMAPs. They were really focusing on the galacto-oligosaccharides, which are the legumes, and fructans, the wheat, garlic, and onion. Mm-hmm. And they found very similar efficacy rates between that and the low FODMAP elimination diet. So it may be that we took the diet too far. That's what I'm kind of thinking. Mm-hmm. And maybe more of a bottom-up approach is going to be the direction of this. We need more data, but in clinical practice, that's been the route that I go.
Great. So maybe as clinicians, APPs that are seeing in patients with IBS, we can potentially highlight some of those foods, like potentially try eliminating the onions, garlic, the legumes. Start there. Maybe the lactose free if that's an issue, before we overwhelm and review the entire low FODMAP diet. And maybe that's something they could try before being able to see a dietitian.
I agree with that. Yeah, definitely.
I have another question for you, regarding different fruits. I understand that prunes are sometimes recommended as a first-line fruit supplement for treating constipation. I know that prunes can have a natural sorbitol, actually is a high FODMAP food, natural sorbitol content. There's also soluble and insoluble fiber components to it. And there are some recommendations to try 4 to 5 prunes per day, more for constipation, less for IBS. And I know a lot of my patients find that to be beneficial, but I'm reading more and reviewing some studies on kiwi fruit and how, 2 kiwi fruit a day can really be more efficacious for patients, particularly with IBS-C. So Kate, what are your thoughts on prunes versus kiwi fruit for constipation and IBS with constipation?
Yeah, so I adore kiwi fruit and I definitely recommend that top. And the reason being is that kiwi fruit is better tolerated from a GI discomfort standpoint when they've looked at it against Bill Che's group. Also did a study looking at psyllium husk, prunes, and 2 kiwi fruit. And they lined up the amounts, so they had similar amounts of fiber at 6 grams each. And they all worked for constipation. And they were studying functional constipation patients as well as IBS-C patients. But the kiwi fruit was best tolerated. So yes, you are going to have that patient that maybe has functional constipation, and maybe even some of the IBS patients that are not sensitive to the aftermath of sorbitol that can do prunes too. I mean, not everyone is sensitive to every single FODMAP, even if they have FODMAP sensitivities. So it can be tried. I've had many IBS-C patients do well with prunes. So either or, but if you want to go the more gentle approach, which I always want to do more gentle, I don't want patients to have food reactions initially. So I'm going to start with what I know they probably will tolerate, and kiwi fruit is it. So a couple little tips here. I recommend people buy kiwi fruit in bulk. You wash them. That you can keep the skin on, believe it or not. It is insoluble fiber, but if you just chop it up into small little chunks, wash the skin, and throw it in the freezer, then you can just break some off, throw it right into the smoothie. And that is how patients find it really tolerable. You can only have so many kiwi fruits a day, or a week, just chomping them down every day might be less desirable. But if you have smoothies, it's a great way to do it. Now, do not freeze the entire kiwi, because then you'll have like a golf ball floating around your blender trying to break it up. I've done that before and I learned you got to chop it up first, throw it in the freezer. But it's a great way to get the green kiwi fruit. And it's the green that tends to have a little bit more of the laxation effect. There are other types of kiwi, yellow gold kiwi fruits as well. You need to have a little more of the gold. It has the effect, but a little bit less efficacy. So you'd have like 3 versus the 2. So that's a little intel on kiwi fruit, but I'm a big fan.
Mm-hmm. Well, thanks for sharing even your personal experience with freezing kiwi. Now I know, because I need to start incorporating, kiwi into my own healthy diet. So thanks for those suggestions.
Yeah, and it's great because it also has polyphenols. So these polyphenols act as prebiotics. So it has some gut microbiome benefits as well. So I would like to start with some holistic sort of lifestyle recommendations and really get a sense of what you utilize for patients, because we know IBS patients do favor, and they've been studied, a few studies looking at this. They like more of these lifestyle versus medication therapeutics. Not that we can always just have lifestyle recommendations, because some patients and many of them do need medications. But what are some of the things that you use in your practice with your patients to help with their constipation?
Yes, there's a lot of different approaches you can take with your patients regarding lifestyle interventions. And I do want to note that for the sake of our talk, I'll limit this discussion. And there is another podcast, a GAPP podcast, that will focus specifically on lifestyle interventions and less on the dietary piece. But when I see a patient, what are some additional counseling points that I can provide in the clinic? One, just basic dietary approaches, small frequent meals throughout the day, not, avoiding eating in the morning and then having a large meal maybe before bed. We know in the morning, if we have a meal, that's going to stimulate that gastrocolic reflex and promote a really good time to try to have a bowel movement. There's the squatty potty technique, which is the appropriate technique for patients to be able to feel like they can fully evacuate stool. So that is a step stool, which allows your knees to be higher elevated than your hips. You're supposed to lean forward with your elbows on your legs, straighten your spine. And that positioning in particular allows the pubral rectalis sling to open up and allow the stool to send down. A lot of toilets these days are really high, and you're not getting the appropriate angle to be able to evacuate appropriately. Patients also, a majority of patients are going to benefit from, the brain gut behavioral therapies, which I'm a big proponent in incorporating. But diaphragmatic breathing is something that can be counseled to a patient even when they're in the clinic. And that reduces, the autonomic nervous system, allows relaxation. It also provides relaxation of that pelvic floor as far as evacuating, and can reduce anxiety. So that's, avoiding that kind of thoracic chest breathing, a slow breathing in through your nose, allowing your belly to expand, and then slowly breathing out through your mouth. And that's something to even consider before having the bowel movement. Magnesium supplementation. A lot of my patients have tried it and they like it. There's a variety of different types of magnesium. Kate, maybe you have a comment on which one you like better. But, 400 to 500 milligrams of magnesium has, somewhat of an osmotic effect. Think of milk of magnesia, which I believe a tablespoon has 400 milligrams, is an easy supplement to incorporate. And again, a little bit more natural if that's what patients are looking for. I always love our FDA-approved therapies for IBS. I think they should be used in conjunction with dietary interventions for a lot of patients that not only target the constipation, but also the abdominal-related symptoms, the bloating, distension, and abdominal pain. Lastly, we know up to about 50% of patients with IBS with constipation can have an overlapping pelvic floor dysfunction called dyssynergic defecation. So if your patients aren't responding to optimized therapy, always take that into consideration. Consider an appropriate anorectal exam, an anorectal manometry, and potential referral over for pelvic floor physical therapy. Kate, did you have any comments on the type of magnesium before we move on?
Yeah, I think in the ACG guidelines, it has magnesium oxide listed, and you want a magnesium supplement that is not absorbed well, so it will stay in the gut and have that osmotic effect to soften stool. So like magnesium glycinate is well absorbed, so that wouldn't be first choice. But citrate or oxide are generally what I would recommend, and starting at 400 milligrams, agree. Totally.
Great. Thank you. Let's move on now to our second case. This is a 40-year-old male with a long-standing history of IBS with constipation. His constipation has been responsive to prescription FDA therapies. He had been taking linaclotide, but he endorsed ongoing abdominal bloating and distension, which has always been his chief complaint when he has seen providers. Therefore, we discussed a different mechanism of action as far as another FDA-approved therapy and prescribed tenapanor to potentially target more of those abdominal-related symptoms. Over the past 6 weeks on tenapanor, he reported a reduction in abdominal pain, which is great, but he still endorsed a lot of gas, especially after eating meals, and significant abdominal distension. He states that he lives alone, he's trying to lose weight and address his gas and bloating by restricting carbohydrates. And he feels quite overwhelmed. He's down to eating chicken, eggs, and fish. I see this a lot with patients that they become so restricted on their diet because it causes anxiety to expand on their diet, and they are afraid that they're going to have worsening abdominal-related symptoms if they try to expand. So at this point in the juncture of his management plan, I refer him over to, again, our expert dietitian, Kate.
I'm glad you did, because, these patients, they have already established some food fear, right? So they're already restricting. They probably are really worried about changing their diet. And a dietitian has a unique lens because we can look at what they're eating and then come up with a list of foods to start adding that are less likely, less gas producing, less known IBS triggers to add back so that they can have successful reintroduction of food, which will build confidence in their ability to expand their diet. So we always want to be very selective. So I am going to start liberalizing this gentleman's diet with some low FODMAP vegetables and grains, and just slowly incorporating them, knowing likelihood that this is going to trigger his symptoms are going to be less likely because of the data we know with FODMAPs and IBS. So we're going to start with that. We know his low carb diet is not very good from the sense that there's nothing to bulk up that stool, help with elimination, maybe stimulate some mucosis and mucus and help the colon kind of move through some of this stool. And just from a gut microbiome standpoint, we know that fiber is important from a number of different vantage points. So I'm going to start doing that and start slowly advancing his diet with foods that feel safe to him, but also that have been vetted by me without mentioning FODMAPs, without mentioning anything, just slowly adding back. We're also going to really encourage discrete meals. I'm very adamant about these patients having breakfast and kind of encouraging him to know that these safe foods should not be triggering his symptoms too much or differently.
Thanks, Kate. Well, our 45-year-old man returns to clinic to see me. He reports that he had a great interaction with you in expanding his diet and is incorporating, less of the kind of lower FODMAP carbohydrates into his diet and liberalizing his diet. And he feels good with these new dietary interventions. However, he's starting to recognize a perseveration on, his diet, the structure. He's still afraid to leave his home due to potential symptoms associated with laxatives that he's using and just the bloating and unpredictability on when he may actually need to go to the bathroom. At this point in his care plan, we talked about a referral over to a GI psychologist to really navigate those feelings and emotions that he's having regarding his GI-related symptoms and fears. And, I spent some time talking with him about those resources, and he seemed open to those suggestions. Kate, before we end today's podcast, are there any other dietary pearls or counseling points that you can provide for APPs when they're seeing patients with IBS, with constipation in clinic?
Absolutely. There's some key things that, just a quick recall. Are they doing a lot of chewing of sugar-free mints and gum that adds a lot of gas and has a lot of FODMAPs in them? Are they eating discrete meals? Breakfast is key. We mentioned this, Amy, you mentioned this earlier, and that gastrocolic reflex is highest activity is in the morning and after meals. Take getting people to have that breakfast, and they feel more confident if they have the right foods, right? So a GI dietitian can really help set them up for a good breakfast that's gentle on the gut, but will stimulate that bowel movement in the morning. So really, really encourage breakfast. Just looking for some of those foods and beverages that can be big time problems. Too much alcohol is our patients, binging on the weekends. Alcohol intake in general has increased, and really qualifying how much alcohol. Are they having craft beers, but they're 11% alcohol and they're having 3 of them? Really understanding that, for instance. Are they eating a lot of rich desserts? It can cause luminal distension if they're having a lot of fat. Really just, taking a basic recall can really, really go a long way. And then just making sure that they're getting fiber spread out throughout the day. They're not getting 25 grams at breakfast with their 5 tablespoons of chia seeds. Maybe asking them to kind of have a little bit throughout the day and spread that fiber out. That can be extraordinarily helpful. Are they getting movement in? And that is not a diet tip, but I talk about movement every single counseling session, because it's going to stimulate that colonic motility. It's going to move out trapped gas. And that bloating symptom that associates constipation, the bulk of patients with IBS-C experience bloating, that can really be helpful at mitigating that troublesome symptom. So make sure that they're moving. Make sure they're sleeping, and check, are they skipping meals all day and coming home and having a huge dinner? Well, guess what? They're not going to sleep very well. And we know that symptoms of IBS are increased with poor sleep. So, again, some of these little tricks that you just need to, when are they eating? How are they eating? How much are they eating? Are they spreading things out? Are they moving their bodies? Are they sleeping adequately? Those seem like just general basics, but they're really important to ask. And it can really make a difference by just tweaking a few things. They can get on with better bowel movements and a better quality of life. And I will say a GI dietitian can be extraordinarily helpful. And I know that they're not everywhere, and a lot of community physicians and offices don't have access, but we do have a couple new registries. So one thing to pay attention to, the American Gastroenterological Association has started a GI dietitian listing. And you can find that at myagagastro.org and look for Find a Healthcare Professional. So that's a new listing. And then also the Academy of Nutrition and Dietetics has a listing, and that's at eatright.org. So there are places that you can find dietitians with GI expertise to help your patients navigate the challenges of trying to figure out dietary triggers without unnecessary testing and putting patients through too restrictive diets when they might not be necessary.
Kate, it has been a pleasure having the opportunity to talk with you today.
Likewise, Amy.
I want to thank our audience for listening. I would encourage our audience to navigate the GHAPP resources in more detail. GHAPP has a website that you can go to. So again, GHAPP is GHAPP, Gastroenterology, Hepatology, APPs. We also have an app. It's called the GHAPP ACE app, ACE. Please download this app, and it's full of additional resources that will enhance your care for all patients that are suffering from a variety of GI disorders.